Today's topic is acute kidney injury. Acute kidney injury, previously known as acute renal failure, constitutes a sudden decrease in kidney function. It is represented by characteristics such as low glomerular filtration rate, abbreviated GFR, low urine output, or oliguria, and buildup of nitrogen-containing wastes in the blood, like urea and creatinine, a condition termed azotemia. There are three main categories of acute kidney injury, including prerenal, intrarenal, and postrenal. Prerenal AKI is the most common type of AKI. It comes about due to a substantial decrease in blood flow to the kidney, hence the name prerenal. Causes include conditions that reduce the amount of blood in the vascular space, termed hypovolemia, such as severe hemorrhage, and conditions that bring about dehydration, as with substantial loss of GI contents that comes with vomiting and diarrhea. With significant burns, fluid evaporates from the body faster, leading to hypovolemia. Also, circumstances that increase the vasculature capacity and leakiness, such as sepsis and anaphylaxis. These are types of distributive shock. Under these conditions, the vessels are dilated and leaky. The blood pools in the vessels, and fluid leaks from the blood into the extracellular space, so less blood reaches the kidneys. If the pump itself is not working, as with heart failure or cardiogenic shock, less blood will reach the kidney. Also, if the vessels feeding the kidney are narrowed, as in renal artery stenosis, then less blood also reaches the kidney. Two main forms of renal stenosis include fibromuscular dysplasia, which is abnormal growth within the walls of the arteries that cause occlusion of the lumen, and stenosis caused by plaque buildup, known as atherosclerosis. An embolus in the renal vasculature could also block blood flow to the kidney. The intrarenal form of AKI comes about when internal structures of the kidney itself are damaged due to ischemia, toxins, and tubular obstruction. The most common cause of intrarenal AKI is acute tubular necrosis, or ATN, which is necrosis or death of epithelial cells that line the renal tubules. ATN can be caused by ischemia from a prerenal issue, causing lack of blood flow. Other causes of ATN include exposure to exogenous compounds that are nephrotoxic, such as the antibiotics of the class aminoglycosides, heavy metals such as lead, and ethylene glycol or antifreeze, which has a sweet taste and can also cause blindness, so keep it away from your pets and children. Certain endogenous substances produced by the body can obstruct the tubular lumen. Examples of these include myoglobin, released from damaged muscle cells, or excess uric acid that comes from the breakdown of purines, which make up portions of DNA and RNA. Uric acid is released in high amounts during chemotherapy for cancer because so many cancer cells are dying. Therefore, it is important to stay well hydrated during cancer treatment to reduce the risk for kidney damage from all the uric acid. With hemolytic issues, where many red blood cells are dying, hemoglobin in the tubules can block filtrate flow. In multiple myeloma, myeloma light chains can block the tubule. Other causes of intrarenal AKI include interstitial nephritis and glomerulonephritis, where there's an inflammatory issue. Here on the left is a drawing of a healthy neuron with normal GFR. On the right is shown a kidney suffering from ATN, where renal tubular cells die and detach and clump together to form a plug that may partially or fully block off the lumen of the renal tubules. This prevents fluid flow and causes fluid backup, proximal to the blockage. The result is an increased pressure inside the lumen, which opposes the amount of filtering at the glomerulus. Hence, the GFR and consequently urine output are both reduced. The decreased GFR is represented by the smaller, slower moving arrow. Postrenal AKI is due to an obstruction in the urinary tract that is located after the kidney. The obstruction limits or blocks filtrate or urine flow. The postrenal obstruction may be due to a renal calculus in the ureters or urethra, or from a narrowing of the ureter called strictures. Expanding intra-abdominal tumors may compress on the ureters, bladder, or urethra externally and obstruct urine flow. Spinal cord injuries can damage neurons responsible for bladder detrusor muscle contraction and lead to what's called neurogenic bladder that can obstruct urine flow. The most common cause of postrenal AKI is benign prostatic hyperplasia, or BPH, where the urethra is compressed by the enlarged prostate gland to limit urine flow. For whatever the postrenal blockage is, fluid will back up into the nephrons and increase pressure there to reduce GFR, which brings about azotemia and oliguria. Looking at the BUN to serum creatinine ratio can help determine the type of AKI that is going on. The normal BUN to creatinine ratio ranges from 5 to 20 to 1. For a review on BUN and creatinine and where they come from, please see the video titled BUN and creatinine. Remember that with prerenal AKI, GFR is low and the tubular cells are fully functioning. Because GFR is low, the filtrate will flow slowly through the nephron, allowing more urea than normal to be reabsorbed at the PCT. So with prerenal, BUN goes up for two reasons: low GFR and increased reabsorption at the PCT. Creatinine only goes up for one reason: the low GFR state, since it's not reabsorbed. Hence, with prerenal AKI, the BUN to creatinine ratio is higher than normal and is usually greater than 20 to 1. The renin-angiotensin-aldosterone system, or RAS, gets activated by the kidney as a negative feedback response to attempt to increase blood volume and get more blood to the kidney. Remember that aldosterone will increase sodium reabsorption into the blood, so urine levels of sodium will be low in prerenal AKI. Water will always follow the sodium and will also be reabsorbed, so not much water will be in the urine, and this will make the urine quite concentrated and cause the urine osmolarity to be high. With intrarenal, urea is not reabsorbed, since the tubular cells are dying and not functioning. Because of this, urea doesn't go up more compared to creatinine, as it did with prerenal. So the BUN to creatinine ratio is typically less than 15 to 1. Sodium levels are high in the urine because renal tubular cells are dysfunctional, so they can't reabsorb it. Water follows the sodium into the urine and tends to dilute the urine, so urine osmolarity is low in intrarenal AKI. With postrenal AKI, the BUN to creatinine ratio is typically greater than 15. As tubular cells become damaged, the level drops to below 15. Sodium levels in the urine are initially low, but then increase as tubular cells become damaged. Urine osmolarity is initially high, but then as cells are damaged, the non-absorbed sodium in the urine draws water and dilutes the urine. Overall, it could be said that initially postrenal is similar to prerenal, but as the cells are damaged, values become more similar to intrarenal AKI. Here now is a summary comparing the features and causes of the three different types of acute kidney injury. Pause the video for review. Here's a table summary for the differences in lab values for the different types of acute kidney injury. Notice that values for postrenal are initially similar to prerenal values, but later as the cells are damaged, values are more similar to intrarenal AKI. Now for a few questions to assess your understanding. These questions also come from the video before this entitled BUN and creatinine, so you may want to review that. Pause the video and determine your answer. If you answered G, then you are correct. Question 2. Pause the video and determine your answer. If you answered B, then you are correct. Question 3. Pause the video and determine your answer. If you answered B, then you are correct. Thanks for watching.